Hey everyone, enjoyed this second episode of our conversation with Tom Michaud. So this we kind of get deeper into specific rehab exercises. We kind of talk through his philosophy when it comes to training. Brett and him kind of riff a little bit on books and research and stuff like that. And it was really amazing for me to just kind of sit back and listen and really learn. I've enjoyed putting these episodes together because I've gotten to re-listen to it a couple times before you guys, and I've just learned a ton. So if you missed our takeaways from the first one, go back and listen to kind of the first part of the episode, number 1. We kind of get deeper into what we took away from it, things we're still contemplating and stuff like that. So anyway, enjoy this episode with Tom.
Another burning question I have for you, and we talked a little bit before we started recording, in other joints of the body, when we talk about joints that are getting stiff or restricted or losing joint play, we at MPI, we talk about like there either being an internal reason why that's happened, meaning the central nervous system isn't picking the muscles in the most synergistic way, therefore the culminating effect is blockage in a joint, or we talk about like an external cause, which could be an ankle sprain, poor posturing, whatever it might be. In the foot, I would like you to comment, and I kind of teased it earlier when I asked you that question, when we have recurrent joint blockages. So if you're in private practice and you're seeing this patient and you continue to feel the same joint blockage in the midfoot over and over again, and we know that we want to be manipulating, what is the reason for that? What, in your opinion? I kind of have my own opinion. I'm interested to hear like why does that happen?
Motor engrams.
Right.
People develop faulty movement patterns to offload. The better the athlete, the more complex the motor engram.
Right.
You know, I have like Olympic level runners that will strain adductor longus and then rectus femoris, and then they go from one flexor to the other as they offload it. And you see it with plantar fascial injuries. They get a plantar fascial injury, and then they'll get a flexor hallucis longus tenosynovitis because they're producing heel lift by firing their big toe. And that's what we were talking about. I think the future of manual medicine is coming up with functional movement tests that actually work. Like I published something where that worked well. I've been looking at things where I have people like stand on, put them on the toe pro if I'm looking at their toes, and I'll say do a raise. And I just wrote a paper on it. It's going to be in Dynamic Chiropractic soon. That wink sign, when flexor digitorum brevis fires, you see a little crease form at the distal interphalangeal joint because flexor digitorum brevis attaches to the intermediate phalanx and it plantar flexes it. And some people, like I just posted a video on it. She's a high-level runner. She had plantar fasciitis, boot immobilized, seemed strong, everything was fine, but every time she did a heel raise on toe pro, there were 2 toes that didn't make a wink sign. And then when I measured her toe strength with the dynamometer, she had a 50% strength imbalance, but that's a subtle little sign. And then does the interphalangeal joint on the hallux plantar flex after the 5th repetition? Because a lot of these things we talked about, it's not just one muscle test, it's after they fatigue. You know, soleus weakness predicts Achilles injuries. How are you going to check soleus? Face down, bend 1. You have them stand, bend their knees 45 degrees, go to one leg, and do repeats to failure. Compare the 2 sides. You know, if they can't do more than 10. And the athletes or the patient get a kick out of it because they'll almost always say, I knew there was something in there. I knew it wasn't right. Because they feel it when they fatigue. But, you know, how do they put that into words? You go into MRI, is fine. You know, if most physical examination is a waste of time. And what you've got to do is look at movement, because movement predicts just where those motor engrams are.
And I think movement variability, they've found that out with squatting, which is different than what I would have thought. I would have thought the best squatters in the world are going to use the exact same strategy every single time. That's actually what like mediocre squatters do. The people with the really good brains, they're using a different strategy each time, and they're subconsciously making little alterations that they don't even realize they're doing, but they're so clever and they're such a savant with their ability
Bolt is very asymmetric in his running. The best runners have asymmetric movement patterns.
Right.
So that's the kind of neat part about it. And that's what we were talking about, that article on Achilles injuries, where they took people who got injuries and they used ultrasonography to look at lengthening of the fascicles and the tendons, and they showed that the non-injured group had more complex movement patterns. The injured group used the same muscles over and over. And it's identifying those movement patterns, which is difficult. Like anterior reach will predict it. Triple hop test. There are functional screens out there, but I like weird ones. I don't know if they work. Like that popliteus one, you just sit and then you hold your hand against someone's forefoot, knee is flexed 45 degrees, and see if the tibial tuberosity moves. If they're just moving their ankle, then popliteus isn't working. And then you'll cue them and try to get popliteus to move. And you do a flexor hallucis longus, have them push down on the foam. Do you see that distal interphalangeal joint go down? A lot of times that'll pop up. You'll see people walking towards you, their toes will be in the air. They don't even know that they're not using their toes. If you want to see if they are, take the insole out and look for wear patterns. On the injured side, you will see huge wear patterns on the central forefoot, but nothing under their toes. On the non-injured side, you see huge divots where their toes are.
Yeah, it's interesting too. There's multiple muscles that can stiffen the arch. The one that people are always talking about are, flexor digitorum brevis, quadratus plantae, but then there's the abductor hallucis longus. So do you think, like, for example, in that scenario, if we know that muscle is responsible for stiffening the arch, do you think that we should specifically do things to train that individual muscle, or do you believe that your central nervous system should be picking all of these muscles kind of like an orchestra, or what are your thoughts on that?
That's a really good question, and I always go back to that one paper where they took people with altered gait patterns, usually valgus collapse. They strengthened their hip abductors, they strengthened their rotators, 50% increased strength after 12 weeks. They put them on a treadmill and they did the same movement patterns. That's why when I talk about strengthening the intrinsic muscles of the arch, if you strengthen it, you'll strengthen the tendon and you'll give them the option of using it, but they're not going to use it. How you decide what muscles to use during gait is based on all these reflex loops, and your cortex has hardly anything to do with it. They've done multiple studies, which I hope they don't do anymore, where they have cut off the cortexes of cats put them on treadmills, and they walk just fine.
Isn't that crazy?
What controls motion is the mesencephalic locomotor system. It's located in the midbrain. You don't have time for sensory input to go all the way up to the cortex and down. Half of them are monosynaptic reflex loops in the cord and out. So I tell people, if I'm strengthening abductor hallucis, get it stronger, and then 5 minutes twice a day, I want you to push off with your toes. And I say focus volitionally to push down. I make them duplicate the motion. If I want to correct a valgus collapse, I'll take that triple stick strap that we use for blood flow restriction. I put it around the proximal femurs, and I'll say walk and push out into that. So you have to rewire the mesencephalic locomotor system, and it's relatively easy to rewire because it gets deregulated really quickly. So you just have to do repetition. And because you always have to have feedback, whether it's increased strength, increased range of motion, improved joint play. You want to see wear pattern under the toe. So like a lot of people just come in and I give them rehab and send them home. I'll say in 12 weeks, I want to see wear on this part of your insole. So when you're walking, and I don't get a lot of like arguments about it where like that's stupid, I'm not doing it. Most people will say, okay, that makes sense, which is kind of neat. So,
well, I have a quote in one of our presentations that it's actually your quote from your book, For Orthoses, that was the original one that How I Got to Know You, and it basically says that you can't just put an orthotic in someone's shoe. Like, so you have literally the best person in the world at making orthotics, Tom Michaud, but then you're also saying that we need to do rehab, we need to do manual work, we need to do treatment. So I think that's pretty telling. I mean, if you're the best in the world at making orthotics, you think you'd be pushing everyone in orthotics, and that's not what you're telling people. That's not you're not beating that drum. So I think that's pretty impressive for us that are trying to integrate all these different treatment ideas.
Definitely. Yeah, keep going.
The other question I had for you is, we talked about the calcaneocuboid self-locking mechanism.
Yep.
So if somebody, let's just say they're struggling with regirding or resupinating their foot at the end of mid-stance in the gait cycle, are we saying, let's just take the overly pronated foot for example, are we saying that they are unable to do that? Is everybody able to do that because they're bipedal walking, or what would you say to that?
So that's a great question. When you're dealing with calcaneocuboid dysfunction in an overpronator, you have a couple of different things that happen. As the talus adducts and plantar flexes, the forefoot abducts, which interestingly, which compresses the calcaneocuboid joint and can cause it to fail. That paper that I was talking about, where they looked at the effect of rear foot and forefoot varus posts, when they used a rear foot varus post alone, it decreased the degree of forefoot abduction, which would alter the compression of the calcaneocuboid joint. But there's also something called a vertically displaced oblique metatarsal joint axis, and that happens in overpronators. Normally, the oblique metatarsal joint axis is at about a 52-degree angle like this. In overpronators, it's often vertical. So they have a condition where their forefoot abducts in the transverse plane too far, and it offloads the calcaneocuboid. Historically, in the 80s, everybody said they're the most impossible people to treat in the world because that joint moves in the transverse plane in such a way that you can't stop it. But large varus posts will decelerate the rate, which gives muscles more time to control, strengthen the muscles that control it. Flexor digitorum brevis plays a role in how that pulls out, and the post decreases forefoot abduction. So, just like with everything else, treat everything. Treat it mechanically by decelerating with a post, stop forefoot abduction with a post, treat it with mobilization to make sure the mid-tarsal joint has a good joint play, and strengthen the muscles that control that transverse plane motion. Abductor hallucis just so happens to have the longest lever arm to that. It's the farthest out, and it's a thick muscle. Thickness of the abductor hallucis predicts hallux valgus. If you have a thin abductor hallucis, you're more likely to develop a painful bunion. Also, failed surgery with bunions.
So then, what do you think the prevalence is? Because those of us who are doing a lot of joint play, we talk about the calcaneocuboid joint is not a joint we're adjusting every day. Like when it's there, we're of course adjusting it. So how often do you find joint blockage there? And
I don't find joint blockage there in hypermobile flat-footed individuals.
Yeah, for sure. No.
I find it frequently in cavovarus, and then where the cuboid comes in on the Mets, I find a lot of dysfunction. So calcaneocuboid and cuboid fourth and cuboid fifth, especially cuboid fourth metatarsal, I'll mobilize and manipulate that a lot because that just solidifies, and it's that lack. And we talked about it earlier. I think joint proprioception is important, but I think it's the spindle sensing what's happening in the joint that's telling the central nervous system what's going on in there. So I want to make sure you have full range of motion, they're not too tight, they're not too loose, and that they're strong, and that they have good vascular supply. With good supply to peroneals, you're going to have enhanced proprioception. I would love to do a study to see if increasing endurance with like that 2-to-1 ankle rock board, doing that 5 minutes a day, if that, and then measure it with those muscle oxygenation sensors, if increased circulation correlated with enhanced proprioception, which would be easy enough to measure with a closed eye Romberg or like an anterior reach. I think it would, and I manipulate cavovarus all the time. Hypermobile hypermobile flat foot, first metatarsal is almost always lifted up on the cuneiform, so I'll manipulate that. They're so mobile though, you just shift them like this and in positions, when they walk out to their car, the ground reactive forces are going to push it right back in that position.
Right.
So you got to strengthen Peroneus longus to pull the first met down. What muscles control it, and how do you offload it? So I'll strengthen Peroneus longus a ton. I'll strengthen abductor hallucis. You just look like geometrically what muscles are controlling those joints and strengthen them. And then do you strengthen them for force output? An athlete should do. If your goal is just muscle volume, those light resistance protocols, 4 times 25 at 30% full effort, produce the same hypertrophy as measured on MRI as heavy weight training. But you don't get the force output with those protocols, you just get the muscle mass and improved tendon resiliency. So for an older athlete who just wants to make their tendons resilient, people over 50 are 10 times more likely to be injured lifting weights than people under 50. So I like to offload those older people, like myself, and then focus on high force output only after you've got the strength back. So again, you got to look at it in every plane. It's not, some people, when your only tool is the hammer, you see everything as a nail. Some people will throw an orthotic and then turn their back on it. The podiatry profession as a whole has totally overlooked the role of the muscles. And I just did a study at Temple University, the podiatry school. They took that toe pro and they took 25 people. They wanted to see the effect. They're starting to look at it now, to their credit. And I think they're going to be quick adapters to it because it's logical. And they had people do just 6 weeks of that toe pro, I think 2 sets, and they had increased force output under the medial forefoot and increased strength in the toes. And prior studies have shown that you can get stronger but not have any change during the gait cycle. This produced a change during the gait cycle, where during push-off they had more pressure onto the first method, which to me meant that Peroneus longus was firing. And Peroneus longus is a key stabilizer, especially in a hypermobile flat foot or any flat-footed individual.
And as we talked about earlier, we know that, and our listeners probably, if they haven't seen your wonderful pictures in your books, the Peroneus longus is actually a first metatarsal plantar flexor, and that's actually really important if we want 65 degrees of dorsiflexion of the great toe. Otherwise, we create that abutment and that functional hallucis limitus. So we can get lost in the minutia of the mechanics, but I think your pictures in your books are so eloquently done to kind of like show it's just an architectural marvel, this foot.
Thanks.
But if you don't understand, like you were saying, like exactly what these muscles are doing, like it would be very difficult, I think, to treat the foot well and to understand exactly what's going on. So I think my experience with teaching for almost 20 years is a lot of times the students, they don't understand these functions of muscle, or like tibialis posterior, they think of it as a plantar flexor inverter, but how important it is for controlling dorsiflexion and eversion.
Right.
Like no one ever talks about these other important functions of the muscles. But I would highly recommend in the book, I don't know what chapter it is, I just know the original book, you had 2 chapters, and they basically, the first was everything that should happen in the foot in the gait cycle,
yeah.
And then it was everything that went wrong, and it was like a wonderful way to learn, like on how to do it. And I think that's
chapter 3 and 4.
Yeah. So I think it was 2 and 3 maybe in the foot orthosis.
Exactly.
But the pictures are great, and I think you've definitely done the best job of any book that's out there. The other book I reference often is Val Massey's book, but I think your book is way better. I want to switch gears a little bit, if you could hand me the injury-free running. And to me, I think this book is kind of like serves as like an abstract version of human locomotion. If I ever need like a quick brush up, a lot of times I'll pick up injury-free running. But new to this book here, and I'm so excited to hear you talk about this right now, you have a section where you kind of talk about like someone who might not be seeing a bunch of runners. You could look at your runner on a treadmill or on video and just some like really key points, like maybe you don't want to like take it to the level that you're doing, but what are some key things that you would be looking at if you had a runner, on a treadmill?
Great question. And I talk about it. Part of the reason I did a new edition of that book was because of one paper that came out in 2017. I'll send it to you. They took 100 runners and measured 3-dimensional motion, oxygen consumption, lactic acid threshold, all these markers for fitness and markers for efficiency. And they showed that the best predictor of both performance and efficiency, because some markers were good for efficiency, shorten your stride, don't have much up and down movement. Other markers were good for speed, the speed their ankles plantar flexed. But the one marker that predicted both best performance time and efficiency was the position of the tibia when the foot first made ground contact. If it was within 7 degrees of vertical, so it usually was just 7 degrees forward of vertical, so the foot was slightly forward, but it was pretty much almost a perpendicular tibia, that had the highest correlation with efficiency and speed. Lowest braking forces. Everybody for the last 15 years has gotten into this heated debate about landing on your midfoot, and heel striking is horrible. And it's like Republicans and Democrats. It's like one or the other. There's like no convincing one that the other one is there.
You're not going to change your mind.
So why bother? So what this showed, a prior study showed that when they measured impact forces, that people who struck with their ankle dorsiflex 20 degrees on the heel had less shock transferring up the extremity than someone who landed perfectly midfoot. and someone who landed with the ankle plantar flexed had less shock, which makes sense. If you land on the heel, tibialis anterior, muscles lengthening under tension is how you absorb shock. So if you land on a flat midfoot, you go right to the knee. But what really, and then everybody said cadence, and just cadence. But what they show is that heel strikers sometimes will overextend that leg. So this debate began because a lot of heel strikers had massive braking forces. When you land on your midfoot, you tend to shorten your stride a little bit, and you can't overreach.
Right.
But a heel striker can overreach. And what do they do when they're overreaching? They're taking their tibia and they're bringing it at a more acute angle, which means there's going to be more braking force going back. So if you're, it turns out for efficiency, it doesn't matter whether you're a heel striker, midfoot striker, forefoot striker. What does matter is that you have to land with the tibia near vertical.
How is that different? We use that cue quite a bit at our office when we're changing, when we have to make an adjustment to running technique, but we usually work on having the strike point underneath their hip. Are we saying the same thing as far as the tibia? I mean,
as a metaphor, yes, because that's another thing people always say. They say land with your foot beneath your center of mass, but I've always felt that was physically impossible because you would have to shorten your stride up too much. So there's a series of papers in there. It was really hard to find because no one looks at it. It's easy to measure. They took runners of all different levels up to world class and then had them run at different speeds. And they showed that as you ran faster, you brought that foot farther and farther in front of you. The fastest runners hit with that foot over a foot in front of them. Slow runners would land with it 4 inches in front of their center of mass. So it's all about stride length. When you want to run fast, you open up your stride.
Tom, in his book, he exposes, this just blew my mind, Bolt 16 feet.
Oh, yeah.
One stride,
Yeah,
16
cool
feet.
Yeah, and the average recreational runner is like 6 or 7 feet.
Well, that brings us to a really good point that I've never found someone who can answer the question, so you'd be the one. So we're able to decrease our chances of posterior shin splints and things like that by bringing the stride point more underneath. But exactly like you said, well, what about these people who are having to sprint? Then you have to...
That's what I talk about.
Yeah, so then
the
what do we...
sounds good in theory to say change your cadence and land with your foot here, but it doesn't match the real world. So if you're treating 210 marathoner, you're treating world-class people, you can't say run with a cadence of 180. The best runners have cadences, marathon runners have cadences of 205 and stride lengths of 9 and 10 feet. So they don't have the option to land with their foot beneath them. So what I say with that is like what we talked about with everything. Learn to manage where the force is being absorbed. Payton did a study where they took high-level runners and they looked at where is the force absorbed. That's why when they made a big deal about are you a heel striker, midfoot striker, forefoot, the ankle is not a good shock absorber. The subtalar joint is a terrible shock absorber. It barely absorbs shock with walking. It's incapable of absorbing shock. The knee lengthening under tension is huge. What they showed in this one paper was as the people increased their stride, posterior rotation of the hip was the number one factor for absorbing impact forces. So I do a functional test where that airplane, the McGill airplane thing, where you have them hold the leg out and then they move their hip up and down. I find that people who get injured, no matter how many times you demonstrate that to them, they can't do it. Like they're like moving their head. They're like, they will not move their hip. So I give them hip exercises. I'll give them hopping exercises. I want to teach the posterior hip rotators to absorb shock as the shock comes through that proximal femur. So absorb shock in the hips. And not just glute med. Glute med is way overemphasized for importance. Glute med, when they did a study on which muscles are the best at controlling valgus collapse of the knee, which is the number one cause of injury, not just valgus collapse of the knee, excessive internal rotation of the knee. You'll have people coming at you and they're running. They're not doing a valgus collapse. The femur's turning in. That's way more problematic than any other biomechanical problem. No one has ever attempted to figure out how to fix it. I have found that if you do hip rotator strengthening, side-lying rotation, there's a bunch of exercises in there, works like a charm. And you have to improve how supple the posterior hip is. If you do a long axis compression of the hip manually, you were doing it at your seminar, you did one side lying where people who don't have good horizontal flexion, they will have impaired shock absorption. So with every runner, I want to make sure they've got good horizontal flexion in the hip. They should be able to horizontally flex 35, 40 degrees. And hip mobility. Hip mobility is key. And that Kim Nadeau is a trainer. She made a couple of videos for me, one on piriformis syndrome. She does a hip opening maneuver that I love, that I recommend to everybody to improve hip mobility. So if you go to that human locomotion site, just go to videos. Kim Nadeau is a trainer, then piriformis. She did one on core, just my favorite core exercises, and that's good for people with impaired proprioception. But for hips, you can't beat that.
It's interesting too, because if you look at a foot, it's hard to deny from an engineering standpoint that we're not designed to land here. And if you read Tom's book, he'll tell you that actually, ironically, and this goes against conventional wisdom, bones like the calcaneus or the sacrum, they actually have like really thin cortical shells, which I actually heard you speak of last year. It got me thinking about it, reminded me of that, which is basically the exact opposite of what you would think. So, but we have all these like wonderful force dampening areas in our body. So it's always fascinating for me to kind of think about, like, is everyone's telling us to run with a mid or forefoot strike, and then the irony is you're staring at a foot like, well, okay.
Well,
and I think
also another interesting thing. There is a ligament that attaches to the fat pad that stops it from being displaced when you strike on the lateral side of your heel. It took 4 million years to put it there. like it's there for a reason, because they have hundreds of footprints dating back 4 million years. That every single one has been a lateral heel strike. And in fact, a medial heel strike is correlated strongly with injuries, but a lateral heel strike is correlated with lower injury rates.
And Tom talks about a paper in his running book where you actually become more efficient with the heel strike. I think it's like at a 720 mile an hour. I forget. I think it's right at that marker.
Yeah.
So it just, not that that's so important, except for it just exposes the fact that it's probably a little bit individual, right? I mean, I think you always say, like, we want to be really, really careful taking someone who's a rear foot striker, making them a forefoot striker, and maybe that leads us to another good question. When do you change it? So I'm assuming like a heel, like if someone is a mid or forefoot striker, they're going to be plagued with more Achilles tendon type issues probably.
Yeah, I'll switch a forefoot striker in a heartbeat to a heel striker, but they don't do it. I'll try to encourage them to do it if they have.
Tom's the most blatantly honest person.
They love it. They're drawn to it, and it's a pretty running style to look at. It's smoother. A third of the world's fastest marathon runners do it, but it loads the plantar fascia more. You have a double peak on the Achilles and on the plantar fascia. When they put strain gauges in on the Achilles tendon in particular, during contact, the ankle's plantar flexing with a heel strike. The Achilles tendon is not loaded, but you have especially a forefoot strike, it doubles the load on the Achilles. They're already near loading that to the point of failure, so why would you push it harder? But I have had people with good distance runners with horrible plantar fascial injuries to get them to switch. It's been difficult. And I have also had a lot of high-level runners who, at the insistence of their trainers, went to more forward contact, who developed plantar fasciitis and forefoot stress fractures. The injury rates with that switch were astronomical.
And then in reverse, it seems like if you have someone with knee pain who maybe they're a heel striker and you make them a forefoot, sometimes they do get a little bit of relief by making that transition. Would you agree with that or no?
Yeah, but you can get the same reduction by shortening their stride and making them hit with a tibia vertical, landing with the foot beneath their center of mass.
Right.
But they don't like that. And if they're slow runners, this was really clever. This came out in 2017. McMahon originally talked about it 20 years ago, that running is defined by an airborne phase, right? And he said that's other researchers said that's the distinction. And he said, no, most low runners have one foot on the ground. Yeah. What defines it is their center of mass is low. So he changed everything and said, quit with the airborne. And it turns out 16% of all runners are never airborne.
Right.
So these researchers, I think it was 2017, Medicine, Science, Sports, and Exercise, called it ground running because you never left the ground. And they had people run at the same mile pace, like say 13-minute mile, And when you did a ground run versus a little airborne phase, at the same pace, you decreased impact forces by 35% with ground running. But as soon as you had that airborne phase in there, you got into trouble. So if someone's got knee pain and they're like an older recreational runner, I'll say just do ground running. The beauty of that ground running paper was that the entire gait retraining protocol was one sentence. When you run, always keep one foot or the other on the ground. That was the entire training. And then people said, okay. And then they went out, and the problem is, and we were talking about how do you treat elites because they're different sets of rules. You can't run faster than like a 1250 mile with ground running. So if you got like a 8-minute miler, you can't say go ground running, but you can say make your tibia vertical.
Is there any benefit to training, adding that into training then?
Yeah, it's a great warm-up. And this was interesting. It was metabolically more expensive. So probably because the people didn't know how to do it, because our central nervous system calculates the cost of every movement and then adapts to reduce the metabolic cost of it. And that all came from the evolution chapter. And so ground running for a month would be metabolically more expensive. That gets back to that research. You can't change someone's gait pattern without making them less efficient. That's what I originally bought into when I wrote Human Locomotion, and other than saying that sentence, I kind of avoided the subject. But then Competitor Magazine a couple of years ago wanted me to write an article on running efficiency, and I said, there has to be a way to make, like, you can't always be right.
Right.
Because when you get injured, you develop a gait that's not good, and you might be efficient. So then all this research came out that showed if you wore like a backpack that had 20% of your body weight on it, when your foot hit the ground, your central nervous system said, whoa, that joint is using up too much energy, that joint is flexing too much, because efficiency comes down to making your tendons store and return that energy, and it comes down to spending less time on the ground. The less time you spend on the ground, the more spring you have on your tendons. So I thought, everybody can't get that right. What we're metabolically fine-tuned to do is to save calories. But what a paper showed was when they put them on this weighted vest and then had them do sprint trials, they got faster and more efficient. And I thought, that's a beautiful paper because the individual central nervous system figured it out. It wasn't me saying land on your midfoot and then land with your foot beneath you or extend your right hip. It was them going, this doesn't feel right. And their mesencephalic locomotor system saying, you just spent 2 extra calories on that and shut it down. So it improves springiness, reaction times. And if you could, it's that isometric impulse. Remember I said they put those turkeys on the treadmill, gastroc isometrically tensed, and then the tendon stretched and return energy. That can be learned. So the timing of that sometimes requires a little bit of a nudge. So the agility drills can do it, putting resistance on you can do it, making your tendons more resilient with isometric exercises can do it. So, and that stuff applies to high level runners too. So, slow runners I know won't put weighted vests on, but you don't have to do that study. They put 20% body weight, which I did, and my knees were killing me. But I like 10% body weight is fine.
What do you think about, like, for our avid runners out there, changing it up a little bit? So doing some rear foot striking, doing some midfoot striking, like switching it up, or not an important detail?
Yeah, I switch up sneakers maybe, but I wouldn't play around with it. I'd want to get a motor engram for the best gait for me.
Right.
So like I used to tell people, it depends on your history pattern. If you have a history of retropatellar pain, then go to a more forward contact point. If you have a history of plantar fasciitis, go to a heel, or Achilles, go to a heel contact point.
And do you think the people who are like naturally born forefoot strikers, they're essentially just doing this from the beginning and that's how they run?
The only natural born forefoot strikers I have ever seen are sprinters, and they do that because sprinting is a different beast. They don't fire their tib anterior, they hit with that foot coming back already. Sprinting is not anything like endurance running. They're like, it's just an amazing process. And endurance running is more about saving energy. Sprinting is, I don't care, I'm just gonna get this leg back as far as I can. first they maximize stride length, and then when they've maxed out on 16-foot stride lengths, then they maximize cadence. So there are things they're doing now with sprinters where they're saying, we've got to increase your ability to turn over your hips quicker. So they're having drills to increase their cadence. That was another thing that made me think people don't naturally select the best stride. They select what's best given their restrictions. So if you had a sprinter who was really flexible, they would have this crazy long stride, but they wouldn't have the neural drive to increase the cadence to make things go well.
Right.
Or a sprinter who was really tight. So look, is there a limiting factor in there? So, which gets complicated, but it makes it interesting.
Mm-hmm.
But with distance runners, it's all about efficiency. So, and prior injury, the best predictor of future injury is prior injury. So if I've had an athlete who has had multiple metatarsal stress fractures, all sorts of stuff, I feel totally fine saying go back on your heel.
And it's funny too to me, like when we talk about the efficiency of runners, you in your book you highlight I think the English marathoner Ratcliffe, maybe?
Paula, yeah.
Where her upper extremity movement is basically just going everywhere. And I think like if you're around sprinters, you'll see like the movement of the arm is almost methodical. And it's always in the sagittal plane. Like you would never be moving your arm outside. So it's kind of fascinating, even like the difference. I mean, to me, why is that? I mean, you would think still like in an endurance runner that like you would still want to have efficient movement. Do you have an idea why that would be or not?
Yeah, with endurance runners, the arms are moving in the transverse plane. With sprinters, think if you had someone jump off a 3-foot platform. They showed when they measured impact forces, if they moved their arms down at just the right time, there was less impact force. So sprinters will use in the sagittal plane, they'll use their arms to accelerate force and drive. Runners are trying to save energy and their arms are moving in the transverse plane minimally. Mm-hmm. It turns out arm motion isn't that important, but it is. There's some new, Lieberman just came out with a great paper on arm motion, how it can offload the upper trap, how certain lever arms, I'll send it to you. Arm motions are important, but not that important. Mm-hmm. Just minimal. No crossing over the midline. Salazar had some of his runners change their thumb position. I think that's taking it too far.
Right.
Yeah.
Got to roll with that placebo. Do this, and it's going to make you faster.
It's going to be amazing.
Yeah. What else?
Brett, did we hit all the points? What a fascinating conversation.
I think the one thing that we haven't quite touched on, I think it could be a good way to maybe wrap things up, is the people listening are most likely going to be physical therapists or chiros or students of one of those two. And I think we've all had our frustrations with the world of podiatry, so kind of like seeing like what a great niche this can be. How do you view, because these are all going to be like contemporary chiropractors that are listening here or physical therapists. So it just seems like there's such a void out there for somebody who's doing the stuff that the three of us are doing. So could you comment on that?
Yeah, I've been mixing up. I grew up in the orthotic industry. My mom was one of the first workers at Langer Orthotic Labs who they started out making 10 pair a week in his garage in the 70s, and by the early 80s they were on 4 continents making 2,000 pair a week in the New York lab. So I kind of grew up in that industry. I grew up around podiatry, so I know like the entire like way of thinking. And then as a chiropractor, I know our way of thinking, and over time, I think unless you know both disciplines, you're going to do a disservice to your clientele. But by the 10th year I was practicing, and I'm no great manual person. I'm just like regular run-of-the-mill chiropractor. But I had over a 1-year waiting list to get into my office when I took insurance. And it wasn't because I was this gifted chiropractor. It was because I knew clinical biomechanics and I could couple the two. And people started hearing about it. We're at a spot right now that I feel podiatry is not looking at muscle function as well as they should. And chiropractic is not doing a good job with understanding what you can do with an orthotic, partly because of the way they're educated. But now you're in a nice spot where understanding what varus and valgus post by themselves do, understanding strain training, understanding joint mobility, like PTs, trainers, chiros that know this stuff, it's a whole world out there of a lot of people that you can help. And I get people in, I still see new patients on occasion, usually people who've had failed surgery syndromes, like people who are considered complicated. You measure toe strength, you measure hip rotation strength, you do some functional tests on them, they get better. Like, this stuff works unbelievably.
This stuff actually works.
And it's simple. And they get mad that something so logical wasn't presented to them. I'll get, why did the head of the orthopedic department not mention this to me? It's like, I know him. He doesn't know the first thing about rehab. And he's like, they're nice guys. It's just not their thing.
Yeah.
And they don't want to do it either. So, because they do surgery. And that's what I say when people are coming in here. It's like, you're not going to see a surgeon for rehab. You're going to see a surgeon when you need surgery, and that's the only reason. So we're in a nice spot where we're taking care of 99% of the population, because I hate to say it, most of that surgery is unnecessary. You saw those 3 studies where they did arthroscopy on 300 people, put the scope in, and then the next 300 they did nothing.
Oh,
same
and
outcomes.
yeah.
They did the same thing on shoulders recently. They did it on facet blocks. They did it on epidurals. When they do it on hip labrums, they're going to find the same thing. So, get them out of the surgeon's office and get them seeing people who know this stuff, and not someone who just knows one thing. Not that if your only tools at him, you see everything as a nail. You learn just the basics of all these 3 things and couple them together, throw some fascia work in there, enhance proprioception. You can get anybody better. And our healthcare system is falling apart. And I get people better for 10 cents on the dollar compared to everybody else. I hardly see people. I'll have them come in a couple of times. And this stuff works. And it's very cost effective.
And I'm assuming, I've never heard you specifically say this, but I think what I hear you saying is you're probably doing maybe less orthotics than you did 20 years ago, maybe?
Yeah, definitely less orthotics than I did 20 years ago. People used to come in begging for them. They still do, but now I can talk them out of them better because there's other options. So I probably only make 2 orthotics a month. I used to do 5 a week. So because again, times have changed, and I didn't have the tools back when I started practicing. When I wrote foot orthoses, that was strictly like a podiatry logic. Because that's how I was trained. And I threw in some stuff from chiropractic, but that was mostly podiatry, which is why I caught on so well with podiatrists and didn't catch on that well with chiropractors.
What do you think right now the whole mechanism for why our soft tissue techniques are working is being questioned right now? Meaning like the whole adhesion fibrosis model, like that they're saying that that's probably not what's actually going on, which brings us to this question. 1, how do we decide to do a soft tissue technique? And 2, is it all neurophysiologic? What's the mechanism that's actually...
I think it's all motor engram, neurophysiologic. Like Jeff Bove wrote a great article a couple of years ago saying trigger points don't exist, that the inter-rater reliability of them is poor. But Carla Stecco showed that people with muscle pain have epimysiums that are too narrow, so they don't get high hyaluronic acid flowing to them. And it's that stiffness pattern. Like, there are predictors of injury. It's not that we're wrong. I'm convinced we're right. We just have to figure out why. When I talked about the Optigate system, how people, if they have too long of a dwell, it predicts injury. I wouldn't get bogged down in the weeds whether a trigger point in glute medius was causing a problem, but if they had contraction where they lost 60% of their range of motion, and then you put them on an Optigate system that measures within 1,000th of a second that they have a dwell, or if you don't do that, do a triple hop test, they can't go as far, and then you fix it and they can. Isolate the tests that predict injury and fix it. And improving tendon resiliency is key. Anthony Kay did a study where he looked at ultrasonography on tendons, and he did different muscle energy, and I talked about it at the lecture. That neutral position stretch, when the ankle was at 90 degrees, when you pressed, relaxed, and pulled, held it for 10 seconds, then went back to the start, pressed, relaxed, and pulled, 20% increase in tendon resiliency immediately. So I want to increase tendon resiliency. I want to use isometrics in a lengthened position. I don't do any trigger point work anymore. I'll do muscle energy stuff, but all that neutral position stuff. And then a lot of agility drills and a lot of isometrics. Isometrics increase tendon strength, they increase resiliency, and I look for big asymmetries in motion. And then I do the functional tests on them.
Right.
And now if they have toe weakness, if if you have toe weakness, but it all gets complicated. Like I see people say, well, manual therapy, the whole fascial adhesion thing doesn't work, but it just hasn't been proven yet. They did a study, New York Chiropractic College, what's his name was there, Kevin Ball. He did a study where he measured three-dimensional motion in the ankle, and he showed that manipulation altered the location, the instantaneous axis of rotation, in the short term and the long term. He presented it at the International Conference on Spinal Manipulation, but he never published a paper on it. I'm waiting for more people to do that. I think that manipulation alters the instantaneous axis of rotation in a joint by stretching asymmetric capsular tension. And then the next step is to improve motor engrams to the muscles that control it. And when you're dealing with low back pain, they have shown that thinness of the multifidi predicts it. And they did a study where they put EMG needles in and they say, oh, back extension, Supermans, that increases EMG activity. And then a researcher said, well, it's great it increases EMG activity, but it was decreased volume that predicted injury. So he did a study where he gave people exercises where he measured volume, and only isometric contractions increased volume. So when I read that paper, I switched to isometrics and started getting really good outcomes. So adjust to the literature. One thing I like about orthopedic surgeons is that they're not all sensitive if you say something doesn't work.
Right.
Like all the knee guys I know, when it showed that the meniscus stuff didn't work, they're like, oh, I won't be doing as many of those.
Right.
Well, with us, we just need to like modify what we're doing and then understand why what we're doing works. I think it works by altering instantaneous axis of rotation, which they have proven in shoulders. When they put silk sutures inside a glenohumeral joint and then move it, the instantaneous axis of motion shifts. If you mobilize that, I think you can lessen labral injuries with that. So I like Jeff Bove's thing. I like get rid of the concept of the trigger point, because it's not held up the test of time, but decreased hyaluronic acid, impaired spindle activity. We're coming up with ways to measure spindle activity. That's what those motors do. And we're coming up with tests to evaluate tendon resiliency. That Optigate system where you're measuring hopping measures tendon resiliency.
Sounds like we're back to manipulating joints and doing rehab to me, I think is what I hear Tom saying. So whenever in doubt, no matter what joint we're at in the body, it keeps coming back to that, doesn't it? I mean, it's the combination of those two things together that definitely are producing the best results, and maybe having the longer lasting results also, I think is the other good point there.
Yeah.
Awesome, Tom. What an awesome day!
What an awesome you guys
time.
asked good questions, man.
Yeah,
so let's we'll hold up both these books are an absolute must-have. If you've you need to get both those books, but if you've never seen Tom in a seminar format, he will be at the MPI Gates seminar, which I'll be there also. Taylor will be there. And Mark, Dr. King and I always talk about what a special time that last seminar was. So we're looking forward. COVID kind of messed us up this year, but we're live again in St. Louis in November. So if you haven't seen Tom before, come hang out with him there and watch the magician at work. And what an honor, what a pleasure to be here. I've looked up to you my whole career. I have literally memorized your books, and you are an absolute maverick in what you're doing and pioneer, so I really appreciate that.
You guys are fun to work with.
Yeah, Tom, awesome.
Yeah, really a blast.
Well, the best way to get your products is humanlocomotion.com, correct?
That's it.
It's got everything. It's got all sorts of amazing stuff. You're actually a great follow on Instagram, too.
My wife does that. I never turn my phone on. Like, she'll say something to me, and I'm like, I don't know what that is.
So,
I don't even know where my phone is.
Your wife's doing a great job, so that's
amazing.
The wives,
So anyway, guys, I hope you learned some stuff from Tom, and I know I did. I can't wait to go back and listen to this episode. It's probably several times, but thanks for allowing us to kind of invade your space and invade Boston, and we'll until next time, right?
Beautiful.
All right,
hey,
thanks guys.